Wonderful. Thank you again for joining us for Creative Healing for Youth in Pain, or CHYP's January webinar, Understanding Your Teen's Brain, Differences in Brain Development and Impact on Anxiety, Depression, School, Peer Relationships, and Family Interactions. My name is Ashley Mateka. I'm the Executive Director of CHYP. For those of you who are new to CHYP, CHYP is an online nonprofit organization that is dedicated to empowering youth living with chronic pain to heal by altering the brain's pain circuits through exposure to creative healing experiences, educational resources, and peer support. Today, we are thrilled to have Dr. Susan Donner as our guest speaker. Dr. Donner is a child psychiatrist and psychoanalyst in Woodland Hills, California, and UCLA Associate Clinical Professor and Director of the Child Psychiatry Fellowship's Psychoanalytic Perspectives Program. We're also joined by CHYP's webinar moderator, Dana Pachelski. Dana is a member of CHYP's board of directors, as well as the board of the UCLA Resnick Neuropsychiatric Hospital, and is vice chair of Cedars-Sinai Board of Governors. She is also vice chair of the USC Parent Leadership Circle. Thank you, Dr. Donner and Dana, for joining us today. Before I pass it over to Dana, I would like to go over a few housekeeping items. First, if you have any questions throughout the webinar, please put those in the chat. Dana will incorporate audience questions throughout today's conversation. Second, our webinar is being recorded. A replay of this webinar, along with previous webinars, are available on CHYP's YouTube channel. I'll go ahead and put the link in the chat, and also an email will be sent to all who registered today once this webinar is posted on the YouTube channel. Finally, I would like to ask you to consider making a donation of $25 to CHYP if you find the monthly webinars valuable. Donations can be made at mychip.org/donation, and I'll go ahead and put that link in the chat as well. Now we're ready to get started.
Thank you, Ashley. Thank you, Dr. Donner, and thank you everybody for joining us today. It's a great opportunity that we have to have Dr. Donner here to talk about neurodiversity, which is such an important important topic because it covers so much. And for parents, it really helps us get some great tips on how to talk to our children and what are we working with. So Dr. Donner, I think today will be a really interesting conversation, and I really look forward to walking through, the definition of neurodiversity, what do we do as parents, and we'll cover a lot of great topics. So I think the best thing to do is to ask you to describe what neurodiversity is, what that looks like, and maybe some hot tips on what do we look for? How do we help our children after we understand what that is?
Well, thank you so much for having me. Well, let me start with a basic definition, which is that, the word diversity is very much in our culture now, but the term neurodiversity is actually relatively new, and it's a concept that looks at differences in brain function and behavior as part of the normal variation of the human population. And part of that is really if we actually pay attention to ourselves and to our strengths and weaknesses and ways we compensate, we actually find that most of us actually might have a little neurodiversity, whether we're really strong in one area or weaker in another area and have learned to compensate, or sometimes have never learned to compensate. That's part of that normal human variation.
And sorry,
no, go on.
Well, and I think, what is neurodiversity in terms of what we used to call being on the spectrum?
So typically, the way that autism spectrum disorder has been sort of defined is it's basically deficits in social communication, deficits in reciprocity, deficits in the ability to pretend play, and so it becomes sort of a social and communication disorder. However, there's lots of other potentially very important neurodiverse components that can go along with that core. which has to do with sensitivities, both hypersensitivities and hyposensitivities to various kinds of elements in the sensory realm. And so whether it's lights or sounds or vibration or pressure or even pain. And can be hypersensitivity where there's exquisite sensitivity to some of those domains. And on the other hand, a person, an individual might actually need more of something to be able to experience it. And as you all know, both our children and adolescents and even young adults don't come with manuals. And so you can have a combination of all of these things. Plus, there can be a way that these individuals hold themselves together. If you think about how we sort of steady ourselves and need to hold ourselves together, whether it's through routines, whether it's through certain objects, they may have particular ways of doing so, and as such, may have difficulties with change, with transitions, may have difficulties with predicting what's going to happen next, and as a result, may be experienced by the world as being very rigid and difficult to deal with.
So essentially, we're talking about how the brain is taking in information and processing it. Whether
Exactly.
it's pain, whether it's communication skills, educational styles, at the core, it's really what is the unique brain doing inside of our head that then is putting out these coping mechanisms that the rest of us see and don't necessarily understand. And how do we help them when we learn to speak the language of each person's brain is basically what we're talking about.
That's a very nice way to put it. But one of the things that's most important, because these kids don't come with manuals, the learning is really trial and error. And I work a lot with parents who get overwhelmed that they don't know what to do already, or what a lot of the what to expect books that they read when they were younger did not apply to their particular child. And now they're adolescent, everything during adolescence can start to change quite dramatically. And so the earlier tricks that you thought you knew as a parent, you don't know anymore. And it's a whole new learning world for you and the adolescent. And most importantly, a lot of the learning, it may not happen at a cognitive level. It may not happen at in words. It may not happen with a lovely narrative of, oh, mom and dad, it would be really helpful if you did this for me. Usually it's a crash, whether it's a crash into you, a crash into a wall, a crash into the educational system in one way or another. And then everyone has to sort of bounce back and learn, okay, what's going on and how do we consider what's happening and have to reconfigure and come up with a new plan.
One of the amazing things that came up through one of these webinars was really the concept of helping the child, finding the narrative that works for the child, not putting the child in the narrative that we all think it should be, that we think should be, whether that's the box or the school or the educational style or our parenting style. You know, I mean, what you're saying is really important. And I think what you just brought up is such an important thing, because as parents, we don't realize this, right? Because we are learning on the job and we think we understand our child, and then hormones take over and none of us understand anything. It's a new language and we all don't have a textbook.
Exactly. And part of what happens, although it is hormonally driven, there's a number of other massive changes that go on, not just sort of size and shape, but also the brain. And during adolescence, there's a pruning that goes on where and pruning is a term used to basically things that aren't efficient, neurological pathways that aren't efficient are basically phased out. And so you could think you had a particular kind of kid And all of a sudden, by mid to late adolescence, later teenage, they look completely different. They're acting completely different. And what's so difficult for them is their own identities are shifting, who they thought they were. And sometimes they will cling to various diagnoses just to have some level of equilibrium. And then in that own way, we may want them to be more flexible, but they're clinging. I can't do this because of why. And you're like, but you should be able to be more flexible around this. And that may be a really big sticking point. And how identity is forming during adolescence may also add complexity, because how you see your child or adolescent or evolving, young adult, and how they see themselves may be quite different. And parents often, historically, we've been the ones having to look forward and plan, and may need to actually take a back seat at a certain point and allow the adolescent to start to lead, even if it doesn't look smooth or pretty. But allow them to be able to take a more independent role in their treatments and their choices, so that they can actually have realistic learning opportunities. It's a very difficult time.
Yeah, and is that, what we refer to as helicopter parenting, right? When we're over monitoring because we as parents are clinging to what we know and we think is right for the child, and the child's saying no. I mean, based on their behavior and their symptomology, they're basically expressing a white flag of, I've changed, help, I need some different things. And as parents, we hold on. And one of the things that really helped me, and hopefully you can describe this a little bit, is what goes on in the brain when, as parents, we do hold on tight and we deny those neurons firing and connecting the frontal lobe and amygdala. We're really denying an opportunity for that brain growth.
It's really complicated, because our routines, if you think about them, we like our own boxes. We like our own stability and equilibrium, our own sense of how we're going to stabilize ourselves, our partners, our home life. And all of a sudden, there are massive changes that are disruptive, and it's hard to balance all of that. And the changes are quite, I think, unpredictable. You might have a kid who you may not even recognize as being neurodiverse, and all of a sudden they're doing things that look more impulsive. They may be much moodier. There may be that somebody who was really organized around school or sports or something, their interests may change. So it can be quite shock. And in some ways, the changes can feel almost traumatic, because something you've gotten used to has been so radically changed. And it can take weeks, months, even years for a new equilibrium to establish itself. And knowing, I think, that ahead of time can be helpful in having different grips. I was thinking, Dana, as you were saying, holding, you may have to loosen and be able to have different ways of containment and holding.
And a lot of times we're parenting from our own work, that, things that hurt us in high school, and it's really, or in childhood, or something that happened in our personal life, that then we parent from our own bruised places, so to speak. And so one of the great things that I learned along the way was to take a breath and say, okay, when my child seems dysregulated and when they aren't acting the way that I used to see them act, I have to take a minute and remind myself, okay, let's parent from what my child needs, not my inner child needs.
It's very difficult because there can be overlap and there can be very distinct differences. And for instance, in some families, for instance, one parent may have become quite social as a way of dealing with their own adolescent turmoil. And then when they have a child, an adolescent who actually, for all kinds of reasons, including the chronic pain that they're managing, let alone spectrum or other neurodiverse experiences of the world, that they may actually need not to be so social. They may need to have much more choreographed social situations to maintain their own equilibrium and not be overwhelmed by sound, vibration, lights, body movement, et cetera, et cetera. And so you have a mismatch of expectations of what should adolescence look like, and then being able to adapt that for what should adolescence look like for this particular kid, because you don't want to take away the possibilities of growth and increase flexibility and possibilities as they move towards young adulthood. But you also have to be more realistically grounded with where are their challenges now in real time.
And that brings us right back to neurodiversity as a definition. Is that being above or below the bell curve? What is the bell curve? And if you could just give us kind of that baseline for parents that just joined us again, what are we looking at when we say neurodiversity? It's a new term. It's a catch-all phrase. I know it can go a lot of ways. So just the basic nugget that we could use for this.
And I actually like that it can go in a lot of different ways, because whether from I'm thinking of many of the adolescents that I see in my practice, as they're coming to grips with becoming more independent and having to be more sensitive to themselves so they can be active regulators of their environment, they need to have some of these concepts, some of this language tied to their sensitivities so that they can start to take on their own, not just self-regulation, but being able to think about the environment. And so that can be at a sensory level, being able to think about things like light, sound, vibration, the kinds of things that trigger their pain. Being able to be aware, for instance, many of these kids have all kinds of allergies, whether it's food allergies, environmental allergies, and learn how do they regulate what. Some may actually have higher levels of inflammation, and learning what factors trigger those and the impact on their minds and their bodies so that they can take control of that. But also learning, how do they learn? Do they do better because they have amazing auditory memory and can take notes? Are they better visual learners and need to do better, for instance, on an iPad in class, which can be a thing at this point, getting, sometimes having teachers be flexible enough for some of the newer technologies that they need, but then having to learn to advocate for themselves. And that's a piece that will then translate into them having to advocate for themselves in college and beyond, whether it's graduate school, whether it's in the workplace. And so being able to gain some of these skills in high school, I think, are absolutely crucial.
Understanding how we learn it's the name of the game for the rest of our life. What do we know? And so when we look at neurodiversity, are we looking at this bell curve, right? And in the middle, the curve is somebody who doesn't necessarily have, I'm trying to think of the right way to say this, accelerated either auditory processing, visual processing. They're just kind of the norm in that
I,
category. So you're above or below the norm, and that's what we're looking at?
I, so let me give you different ways that I think about it, because I think the term and the way people are using it can be different. Even if you look at individuals who from afar, because you have to remember, most of us don't have neuropsychological testing to be able to figure this out.
Right.
Their symptoms, their learning styles, their work styles are good enough that they're not getting picked up as being neurodiverse. But there's always a leading edge and a lagging edge for all of us. And if we look at the strengths, if we look at the kinds of things that pull us forward in terms of development, and then there's the parts that necessarily hold us back. They're the sticky points, and they can be emotional, they can be neurological, they can, whatever it is, it's things that don't allow us to move ahead. And the problem is, most of us, I think about this in terms of a fabric, is in between, right? Our bodies, our minds, but they're under such stress. And that's where I think the neurodiversity comes into play. It's when you have a leading edge and a lagging edge, it puts tension on the individual. And that's when you tend to have more symptomatology. You tend to have more conflict, whether it's within the individual or external with their world, whether it's parents, peers, school, workplace, whatever it is, that tension ends up sort of having many, explosions, whether they're big or small. And so it can be at the level, if again, thinking about neuropsychological, it can be as simple as having a really high verbal IQ, but having a visual spatial that holds you back. Having a really good visual memory, but having a really poor working memory, which is what you need to memorize things and pop things out, information out on a test. Or you may remember things that you hear in a movie. I've had patients like this who can actually give me dialogue verbatim after hearing it once. And so they can do fine during lectures, but they may have dysgraphia and not be able to take notes and have to learn that they may need to type in class. So all they're being able to think about the strengths and the weaknesses and how to compensate for all of these things.
And it's so, I love the way you describe this because it's actually a little bit of a moving target. It can be, and it also is really important for parents and educators to really focus on the fact that this isn't a static diagnosis, that this is something that has, it's correct. There are things that we can do to help the process.
Exactly. And I did see a question that popped up. Can I address that?
Oh, please, please.
Working memory is one of these very interesting elements, which is it's how much you can hold in mind at any particular time. And it is exquisitely sensitive to mood, to physiological state, and most dramatically to anxiety. So you have somebody who gets really anxious and panicky on tests, and unless they've come up with ways to override it, their working memory can absolutely shrink. And that can be the role of a good enough therapy or psychoanalysis, where you're able to really work and understand the anxieties so that baseline level really starts to shift. And all of a sudden, you can actually use your mind more creatively and more productively.
I love hearing that because for parents to say, oh, it's really not that the working memory is lagging behind, it's that it's being affected by these other factors that are things that are more readily available to help with coping mechanisms and help our brain then learn a new way of processing, which is the core of what we do at CHYP, right? It's retraining the brain. How do we find our way out from pain? Is not that we're saying the pain does or does not exist. We acknowledge that there's a process in the brain that has been triggered, and how do we work with the brain and all the other cofactors to create new pathways and create new ways out. And I love hearing that in terms of neurodiversity and working memory and all these other factors, that it's the same concept, you know?
Exactly. And one of the things, if whether you think of patients who have chronic pain, patients who, for instance, are on the spectrum or have other, you know, deficits that look like they're fixed. I think, let me use the example of sort of the symptom of rigidity, for instance, even concrete thinking, which is in a good enough therapy, and it can be a really good speech and language therapy. It could be a really good psychotherapy or psychoanalysis, being able to play, whether it's in words or develop pretend play at no matter, at even at various ages, including adults, that play, allowing to be able to imagine things, learn how to pretend, actually creates space for more abstract thinking. And that abstract thinking can lend to creative processing and to increase symbolic functioning, so that that person doesn't have to be that concrete. They may return to concrete thinking at times of distress, but they have much more of a range of their mental processing.
So we're talking, so for example, a child that appears pretty neurotypical, goes to school, either has a bullying episode, has something that triggers them with their heightened anxiety, and then they start to get more and more rigid. They start to have less and less desire to go outside of this safe lane, right? The brain starts saying, nothing's safe, nothing's safe. I'm only safe in this little narrow highway. And that becomes the rigidity that you're talking about.
Exactly. And I think of that in terms of chronic pain, whether or not it is what I call somatic pain, uh, or like in the body. I would say, let's call that a migraine. Let's call that a chronic CRPS, chronic regional pain syndrome, whether it's a chronic pain that never really can go away in various ways, fibromyalgia, there, you know, where there's fluctuations, but the stress hormones, but also the related anxiety and fear keep the organism in this box that's to be able to try to stabilize what's going on. And by definition, it looks rigid to the outside world. And if you don't understand that and you try to push, you're going to get much more pushback rather than working with the child, adolescent, or young adult. And we can see this in us too, by the way.
Right. I mean, the way out is through, right? We have to go into it to come through it, and we have to see it in order to understand what we're working with. And our children are not always forthcoming with their pain, emotional or physical, and then the combination. But it's how does a parent understand how to not push and when to push? Right? That's the hardest question I'm going to ask you today.
It's the hardest question.
I know.
And I wanted to start with the word you said, which was forthcoming. They may not be forthcoming in their words. And part of that can be their use of language. I have found that being able to communicate pain, whether it's somatic pain, psychic pain, which can go on with anxiety and depression, let alone post-traumatic stress, etc., but also the interface, psychosomatic pain, can be the most difficult to put into words. And even, and the, the cute little faces that are used, as you all know, in
Right.
pain
What's your
clinics,
pain level? A 1
right?
is a very sad
I
face. Yeah.
my chronic pain child would just roll her eyes at that. She's like, I live at 9 to 10. Would you like to, expand it, please? Anyways, but to be able to realize that these things may not be coded in words, and that the words may just be placeholders. And sometimes we need to look at the nonverbal communication, the behaviors, the withdrawal, the oppositionality. We may need, for a particular kid, translate what's going on, because they may deal with the pain chronically at such a level that they don't start to communicate it till it's then at at an intolerable level. And by then, it's often, as Lonnie and others will tell you, once the pain is at the high level, it's much harder to treat. So to being able to keep it at a lower level is key. And that's part of them learning about themselves and being able to learn how to communicate and regulate themselves first before so they can be effectively deal with us and the outside world.
Which brings me to two really important parts, which is one, as a parent, right? We don't want to say, how do you feel? Did you have pain? What's your pain level today? And yet we want to get to that exact information. And then that leads me to the second thing, which is when we start to see our kids withdraw, what would be your recommendation for a parent to not say, how are you feeling? How's your pain? Do you have pain? Because those two go hand in hand to me. And probably, one as a parent, the dance that we're doing all day with these children.
I would say part of this is continuing to learn how to dance. And I think it's really, really helpful to have another parent, another caregiver, sometimes a sibling, sometimes a friend, a good friend, somebody else to help you dance. Because when people, and this is all of us, when we get really, really stressed, we do something that the psychoanalysts call splitting. We organize ourselves in very simple ways, which is good and bad. And sometimes there needs to be, in a household, a very clear locus of badness, one of the parents, so that as the adolescent organizes themselves, and then there may be other figures in the home who actually are less bad and are allowed to do things like maybe help clean their room, or maybe help ask the questions. And what I've found is it's often the parent who's most like the adolescent who gets labeled as bad. It's almost like they have to take all the badness they feel about themselves and their difference, their being out of the box, their pain, and it needs to get what we call projected into that bad object. And being able to learn how to tolerate that, believe me, that's a whole new thing to learn, is very, very important, because you're holding something that eventually that adolescent and young adult will be able to come take back and own it, but not till they're more stable. And then to be able to have someone else say, you've been in your room for a couple days now. How about sitting out in the backyard with me? But it might not be you as the identified negative one.
I really love this because I've never really heard it talked about that way, and done a lot of work in this area. And I really love the concept. I always talk about that I'm a bumper on the lane as a parent, right? And when my kids are at this age, I'm this bumper, and then the bumper goes out, and then they get to college, and I'm basically in another county, but I'm still a bumper on a lane. I've just moved that out. And it sounds like what you're describing. And I really like this for parents as a takeaway from today, is to understand which parent becomes which part of the bumper on which lane. And so both parents aren't trying to be the same bumper on a lane, if I'm hearing you correctly.
And that I think of, I've never thought of it in terms of neurodiversity, but I've always said to myself, I like it when parents are different, because when the kids take different parts of us that they do unconsciously, a little bit of this one, a little bit of this one, it gives them more options. What I do also think is important is sometimes it can get very tiring for one of the parents to always be the bad guy. And so to be able to think about mixing it up a little bit, when there's limits that need to be set, sometimes the good parent needs to come in effectively and be able to say, you know what, or you come in as a team if it's something really big and you don't let them split. But again, as you said before, this is a dance, and this is a dance without really fabulous choreography. You're making it up and you're going to stumble. And if there's anything that I think is really, that's my most important takeaway, especially for parents, don't be afraid of stumbling. You're going to do it. It's nice if you can pick yourself up quickly. Sometimes it's going to take a while. And to just be able to have that and realize this is part of your repertoire of learning, that's absolutely crucial to the growth of the system as a whole.
And this dance is an ongoing dance for life. This isn't something that ends very early. And I think, Lonnie put in a great question, which is, how do we help our child that is basically saying, no one understands me? The doctors can't fix me, because of course that's let's just start with the unfortunate concept of we take our children to a physician or to whoever, and they're going to give us the golden key and unlock the kingdom and the pain will go away. And we know that especially for these adolescents that we're talking about today, there's a lot of keys that we need to find. There isn't one, and it takes a team and a village. And how do we help that child who now their neurodiverse brain is saying, no one understands me, I don't even understand me. And we help them say, well, how do you help yourself? And that's a really hot button.
It's a very hot button because you're in this dance of separation and individuation on one hand and dependency on the other hand. And one of the things with both the kids in chronic pain, I don't want to divide them up and make this look like it's clean, because I think there's an incredible overlap, but both the kids who have, whether it's chronic pain or neurodiversity, or those with both, that they may have ongoing dependency needs. Now, the question is how to help them recognize it so they get more specific about asking for help and are less helpless and passive, and have that expectation and magical thinking to a certain extent that someone's going to come in and save them, whether it's a parent or whether it's a particular practitioner. And that crack of that idealized magical world can be traumatic. What do you mean I'm stuck with this? What do you mean this is permanent? What do you mean you can't take this away? What do you mean I need more PT? Or and I have to go back to therapy? I hate this, right? You're telling me I have to fix this and I can't just blame somebody else, which is a sort of an adolescent mantra, by the way. No matter where you are on the neurodiversity spectrum, it's a very painful time, because that separation individuation that can look so typical in some kids is really messy. And it's very painful, I think, on all ends.
And it's painful. And the process that I've found is that I call it the friend that's not a friend, right? The pain has become something you can count on. And it's a friend that's not a friend. And so getting rid of a friend, bad or good, in any shape, right? If we're calling pain a friend, we're calling not a friend. It's definitely not a friend, but it's become that tried and true go-to, and I'm going to call it a friend here for the sake of the discussion. So now when we've had this lifetime of pain and somatic behavior, and now our body's always gotten us out of things that we don't like doing, right? The stomach ache tends to come up when we don't want to do something. And now we don't want the stomach ache and we don't want to do something. And now we're learning, okay, I'm maturing, I've got some new coping skills, I've working with a great team, and the stomach ache is still there or it's sneaking up. How do you get rid of that friend that's not a friend?
I have several cases like this right now. So I'm in the middle of this, which is it's at a certain level, when you look at the pain as an enemy and everybody is fighting the pain, you have your whole team, right? We're all there. Again, there's this fantasy that it's going to get fixed, which can happen in some things, right? And or dramatic improvement. But many of these kids with chronic pain, that's not their experience. The problem is the pain is part of them. And so you're getting this self-other a kind of process going on. It's integrating a part of themselves that, as you said, is a friend. It is there. It's reliable. It serves certain functions, including withdrawal and one of my patients calls it the magic loophole. But at the same time, it's much more compromising. And it's really limiting. And I find that that's often the job of the therapist or analyst, really helping the adolescent see the complexity of the internal conflict. This is not a conflict with the outside world. This is a conflict in the internal world. The part of you that wants to grow and get better, the part of you that is fighting change tooth and nail, and that inner conflict. And one of my teachers, Phyllis Tyson, always taught me that that internal conflict is actually a developmental achievement, because you get us, even though it's very painful and it's the core, believe it or not, of neurosis, but it's this, you own all those parts. You own the good part, you own the bad part, you own the judgment, and you own the responsibility. So being able to slowly work that out, it's not an overnight thing, as much as any of us would love that. It really is a process.
It's such a process, and it's these finite little itty bitty microscopic shifts in the dial, right? Again, everybody's looking for, I'm going to go to this person and they're going to give me the key and I'm going to flip the switch and the pain's going to go away. But with those neural pathways already activated, we know, and the most important thing for parents to learn is that there is no instant rebound back to normal. It's these dials. And I also would like to provide parents and people here to know that when that dial really, each incremental turn of the dial really provides this exponential learning process for later in life. I feel like the people that come through this and learn these itty bitty things, those painful, patient turns later on come back to really help that particular patient in life.
I think that's really, really important. And I know when I had an adolescent with chronic migraine who, when they were in intractable states, there were 2 states that lasted 3 months each, where they lost language and memory. It was very, very frightening. And I found, being a physician did not really help. It did not matter that I was an analyst. I really had to grapple with different ways of thinking about things that I didn't know existed. And one of the things that was most helpful to me is I started looking at things in 6-month blocks. Was this 6 months better than the last 6 months? And being able to sort of put a larger frame rather than, for us, it was hour to hour, day to day, week to week, sometimes month to month didn't work. And to sort of have a larger view and to be able to think, and not just looking, I was talking before about some of the big symptoms, including pain, but maybe we need to be looking at more subtle symptoms, more subtle markers for growth. Did they do something independent? Did they get out of the house? Did they try something new on a project?
Get out of the bed.
Whatever it is. I'm sorry.
Get out of the bed.
There we
Just
go.
get out of bed.
As one of my patients said yesterday, you wouldn't believe it. This is somebody who previously would eat 5 foods and is now 18, and said, I tried 3 new things this weekend. 2 of the 3 really were bad, but I tried 3 new things. And I think the fact that there's that ownership, there's a certain amount of excitement about being out in the world and trying things, even if it's in their limited repertoire. This is movement.
Well, this is the whole concept that Dr. Zelcher's put together for CHYP, right? We're talking about kids that have become so dysregulated that there's school avoidance, there's bed, they don't leave their bed, and the bar is touching the ground for improvement, right? Any microscopic error that can come through is a change. And what do, right? We don't say get out of bed and go downstairs and go to the kitchen. We ask you to get out of bed and go to the bathroom. Maybe go go to the door on the way back to the bed. It's these tiny things. And I think giving parents permission to not look for the magic big response, but these little incremental microscopic things. They're so small, but eventually they make a big thing. And it's hard for parents to see that.
I think so. And when you're living in it and there's so much pain, whether, you can't literally have your kids' chronic pain. And so there is this secondary experience that can be quite traumatic because of your own helplessness. And so it, for good reason, you want to fix to it, right? I mean, but to be able to get help reframing it so that it becomes more realistic. And then when you're more realistic, the adolescent can then in their own way become more realistic. But part of adolescence is pushing boundaries, is denying reality, is being separate on their own terms, whatever that means. And that can look extreme at times, even if it comes to pain. It's a way of being different from you. And I don't think I understood that until I sort of came out of, we sort of have grown up and come out of it. That pain was a friend in that it helped differentiation in a way that nothing else was quite as dramatic.
Well, it's an identity, right? It's just locking in. It's like giving a diagnosis is an identity. It becomes this identity. And whenever we lock into anything, it's definitely not the best or most ideal. It may be helpful for a minute, but it comes with its repercussions or its limitations. And when we're talking about chronic pain and neurodiversity, it tends to accelerate faster into a lot of diagnoses. But I think that the big takeaway, and I always try to say this, that we've seen a lot of patients at CHYP that have been bedridden. They're in high school and the parents are fearful. They're missing 10th grade. They're missing 7th grade. They're missing all the grades. And what's really interesting that I've noticed, and I've seen enough of this through CHYP and in my own life, those kids somehow magically get out of bed and actually tend to do really well and go to college. And so we see at the moment we're clinging to, they're never getting out of bed. We're missing all these developmental milestones, but for some reason they get out of bed and then they go to college.
And I do think that is some, and I think for others to be able to hold that open, the one who tried the 3 foods over the weekend basically made it very clear, I am going to community college. The whole process is too much right now. I have other things that I need to take care of with me. I need to be on a slower road. And it was phenomenally the right decision for that individual. And they had to plant a flag in a family that I think wanted more. And it was brilliant.
And it's so often, and we've touched upon this several times today, which is, as parents, what are we bringing to this party when we're trying to parent our adolescent that's a moving target, right? We want to put our flags in. This is what it looks like. And that I find is when we see the greatest issues with the adolescent, because they're like, that flag wasn't my flag, but I can't tell you that.
And part of it is you may have to plant a flag and then say, oops, wrong flag, and then have to recalibrate. But I think being able to model that is really important as parents and caregivers. If you can show that you can learn, that maybe it's not so impossible.
I think on my personal note, I mean, I had a child who was all of these things we've talked about, very rigid, everything else. And the greatest thing that I learned was to continue learning, was to constantly, which is why we provide these webinars. And I'm so grateful for this information. I'm still learning and will always learn, but I had to keep moving to keep finding new flags and then put it in and say, do we like this one? Or do we like this one? Okay, wait, I'm not going to change the flags too soon, but I am capable of changing the flag. And that dance, again, we're back to this dance as parents. And then I know that, and we've seen this in the chat today, that there are, 2-parent households with diabolically different approaches. And I feel that the takeaway for those families to find some calm.
I think of it like Venn diagrams with the circles with the overlap. Even if you have to work hard to find that overlap, and that can be even in one household, but being able to have a common view, enough of a common view of the adolescent is really helpful, even if things are done differently, that there's a kind of overriding theme around the adolescent that allows for enough consistency in certain ways that allow them not to have an extra level of distress on top of everything else they're dealing with.
Absolutely. And somebody asked what type of professional helps. And I think that's such a broad thing. I think the most important thing that my personal side, and then I obviously would love to hear what you say, is just to find outside counsel. Because the greatest information that I got from somebody along the way is the inmate cannot free themselves.
I love that. I've never heard it, but I will use that, Dana.
Yeah, so it's important. We need help. We need professionals. And even if our child, I can hear the parents say, my child is not going to see anybody else right now. Then as parents, we should, for them.
Oh, absolutely. And I do that all the time. And I even actually do that with adults of grown children when they're either still in the home and there's been a failure to launch for some reason, or a return, or other issues that have come up. There's important parent work that can be done. And what happens is the system can shift to the point that I've often seen the adolescent or emerging adult be interested in their own work. So there's lots of ways to slice bread.
And I love when parents go to a professional, not because they're coming to do their own work, but they're coming to do the work to be the better parent. And I think there's confusion, right? Because as parents, like, well, I'm going to go find a therapist. I'm going to find these people. And they don't believe they can come to somebody like you who really understands these neurodiverse children, who understands the adolescent, and say, help me understand what's common in adolescence so that I understand what's happening in my home may or may not be that different, and give me the tools with which to parent from, which is such a different therapy approach, right? We may need our own personal therapist in addition.
And part of this has to do with, I'm going to go back to the CHYP message, which is the creative healing. I think there's going to be different needs at different moments in time, and to be flexible. For instance, someone who I saw when they were very, very young, sometimes they may want to come back in their 20s, but sometimes they may want somebody else because they don't want to go back and have me remember them when they were 6 or 7. They want someone who's looking at them as an adult in this moment in time. And sometimes people do want the continuity and want to come back because the family, you knew me. But maybe you can help me at this stage too. So again, there's just different ways of thinking about it throughout the life cycle.
Well, this has been an amazing dialogue. I hope that everybody who joined us today, had some takeaways, had some moments where they thought, okay, I'm not alone. This isn't going to be a permanent thing. I mean, if you look at the takeaways, please just know most things are not permanent. And the things that are permanent have different ways of looking at it to help us through. So I can't thank you enough for making the time for all of us, for everybody showing up today to listen to us talk. And hopefully we touched upon the most of the things everybody needed to. If not, I hope we can do it again because it was such a pleasure.
Thank you so very much. And I just wanted to thank Lonnie and Ashley, but a special thank you to you, Dana, for making this so wonderful.
No, thank you. And I remind everybody that CHYP has an amazing website. We also have this recorded and we do keep all of our webinars online. So if there's different things you want to go back to, you can find those or feel free to email CHYP. We are always here to help as a team player and just getting through this because it does take a village. Thank you, everybody. Thank you again.